All right. Stand by. I don't know what I'm looking for. Guys, I'm on mute. I've muted y'all's mic, so just FYI, if y'all want to talk, please feel free to talk because there's so many of you here. But I've muted your mics just in case. So and Rebecca, let you know the gentleman that came into the clinic the other night is highly embarrassed about his being heard. I thought that was hilarious.
That's funny.
That was great. All right, so diving in tonight, it's going over pediatric emergencies. We're gonna I messed up my elbow the other day. It's killing me. We're gonna hit this big chapter. Oh, come on, button. We're gonna dive off into it and get halfway done, call it a break for this evening, and we will ponder what we're gonna do on the rest of that. Okay, we'll skip that. You can read that. Recognizing and reporting abuse and neglect. That is a big, unfortunate thing that we have to do with children, because remember, there is no voice for them. Nobody, they can't really speak for themselves, especially pediatrics in general. They only cry and make a lot of racket. Now, I love kids, but we have to report those when we see them. So we're going to talk about what are some of the implications of abuse and neglect. We'll also talk about that too when we go over geriatrics, whenever I got that scheduled. So we'll talk about some of the things and findings that we're told over our assessment. Upper respiratory obstruction, upper airway obstruction, lower airway reactive disease, that's croup, bronchiolitis, anything viral or bacterial, and respiratory distress, failure, or arrest. That's the worst case we can have. Seizure, shock, and sudden infant death syndrome, SIDS, is very unfortunate. We know that does happen, and there's nothing that we can do to prevent that. That sometimes those things unfortunately happen, and it is a very traumatic situation for everybody involved, all parties. And and for EMS, it is difficult. It is hard in general for us when we're supposed to do our jobs and save everybody and be that hero that we just can't. Sometimes that's really hard. We'll go over some of the age-related issues. We do talk about the age-specific and how to treat children in here. Upper and lower airway obstructions and reactive disease, respiratory distress, shock. We'll go over seizures, SIDS, and gastrointestinal diseases. And that may not be all tonight. You may hit some of that tomorrow or the next whenever I do this again. Recognizing the management of trauma in pediatric patients. The bad thing about trauma in pediatrics is you remember they cope, and then they crash, because there's only so much blood in these poor babies, and when they start losing so much that they can't compensate for that blood loss, and they go into shock, and then they traumatic situation, respiratory stress, arrest, or cardiac arrest. Let's see here. All right, so children differ anatomically, physically, and emotionally from adults. Some do, not all do, but some. Because some adults can act like a baby too. Illnesses. My dear camera's going nuts tonight, y'all. I can't wait. When I go home, it's youth weekend, so ready to go. So remember that children, they're not really small adults. They are smaller humans, but they're not that small adult. Depending on his or her age, the child may be able to tell you what's wrong. They may just be withdrawn and not tell you anything because they don't, how do I say that? They don't really want to talk to you. They're not saying that they're definitely challenged in any form. They just may not be developed enough to tell you, be like, it hurts right here. Or they don't want to talk to you because you're a stranger. Fear for EMS providers can make, Fear for EMS providers and pain can make it difficult for the child to assess. Parents or primary child caregivers parents or primary caregivers may be stressed also. So sometimes when I say you have two patients, a pediatric and an adult, so they're frightened, they're behaving weird, or they're just irrational because no matter what you do hurts. For the reasons of pediatrics, the specialized medical practice devoted to the care of the young patients can be very challenging because remember, again, you got to treat two people. You got to, no pun intended, ladies, but you got to tell mom, calm down, let me have this baby. The more crappy you act, is the crappy that they're going to act. And I'm going to tell you, I can hold my kids down and I'll start an IV and I'm in a heartbeat because I know it's what's good for them. If they need it, I have given IVs to every one of my children. I have given them shots to every single one of them. It doesn't hurt me to hold them down. I am perfectly okay with that. So learning how to approach the children, learning how to talk to them, where to place yourself. Remember, their innocence and opening can be appealing. Children often respond to treatment much more rapidly than adults, but you start low, start at their feet and work their way up. It's like building trust with an abused dog. You got to start from a distance and come back to them. Same thing with children. They don't know you, and now you want to assess them. You want to touch them. You want to see what's hurting. They're bleeding cut on their arm. Now this stranger wants to touch it and it hurts. I don't want you there, so go away. Communication with the patient and the family. Be very foregoing with information, but remember, little ears are listening to you. Pay attention to what's being said and be cautious of what's been said because the children are going to listen. Calm parents usually results in calm children. The parent can often assist with the child's care if they're okay. I will allow parents to ride with me as long as they can keep their composure. If they can't keep their composure, I will stop the ambulance and I will put them out. And I tell them that one is because I'm not trying to be ugly. I'm trying to say, this is my house. I'm going to run it the way I want it. And if you want to ride, we got to go. And it's no disrespect. It's just setting affirmity during a traumatic situation. An agitated parent means the child will be act the same way, which means the child can be more difficult to take care of them. Remain calm, efficient, professional, and sensitive, because remember, these babies are hurt. They're just not saying, oh, hey, I want my sucker because you're gonna look at my ear. No, there's a reason why they called you, and it's not just to come to the birthday party. All right, so we talk about the growth and development. So we know we have spoke about this again, and I would make notes of this specifically for infancy, toddler, preschool age, school age children, and adolescents. And note the ages. You can come out of the adolescence, if anybody's emancipated or anything like that, they do have to show papers. So in most of your trauma hospitals, they're going to separate children from adults at about the 13 to 15. They're going to go from one side of the ER to the adult side. If they're still pediatrics, they will stay on that side. But a lot of times these facilities can treat them because of their size on the adult side versus the pediatric side. And it's not any pun intended towards them. It's just the fact that their body size and their drugs are the same way. If you've ever noticed on children about 13 years old, when you go to give them OTC meds, they're going to be about the adult dose. That is about the time that their body is, I'm not going to say it's finished growing, but it's getting to the point to where it's at a peak and that they can handle the same thing as an adult can. So infancy is usually defined as the first year of life, 0 to 2 months. Infants cannot tell the difference between parents and strangers. Crying is one of the main methods of expression, not exposure. Come on, Chris. Let's see here. An inconsolable infant, after an obvious needs have been addressed, could be signs of significant illness. Now, and I will tell you, if a child that doesn't know you comes to you with open arms, that's not normal. Our normal is for kids to be very standoffish and not be like, I don't know you, but you want to hold me. Um, and most of the time during a traumatic event, you should expect that child to be crying. Their heads relatively give off most of their heat, so make sure you cover them in a traumatic situation, or if it's in a car wreck and there's no longer wearing their hats or anything like that, make sure you find headgear to put on them. So we talk about 2 to 6 months. We know this is where they start to get active. They start crawling. They'll end up starting to scoot. Some of them may try to stand up at the 6 month mark. They can recognize familiar sounds, mom and dad's voice. Their eye contact may be more. They will, the persistent crying, and I mean, what's that say? Depressed mental status, delay of development is when you start noticing at this age. 6 to 12, they start to become turds. They place things in their mouth. That's where your hand, foot, and mouth comes. Majority more from about the 6 months to the 6 years old. They form their own. My daughter's 9. That's why I'm talking about this. They form their own personality. I'm not really say that mine cries when they separated because she's about in the middle of that. She thinks she's bigger than what she is. I'm gonna say 6 to 12 is they don't really put a lot of things in their mouth a lot. That would be more in the younger group. Now I'm gonna say if they persistent crying or irritability can be serious illness, I'll give them that. Provide as much sensory and comfort as possible. Explain each procedure to the patient or caregiver before you perform it, because if the procedure and the infant's reaction may be different. Oh, okay. I didn't know it swapped back to infant. So the toddler. The toddler experience rapid change in growth and development, 12 to 18 months, because they're explorers. They're moving. They're not sitting still anymore. They're going to be all over the place. Last night I had 101 pictures of deer when I woke up this morning, so full moons. Because of lack of molars, they may not be able to fully chew their food, so they're going to gum the hell out of it. At this point, that's their point, is they're going to gum things. They're going to start that drool. You'll notice that when they're teething also. They may have a little bit of what they call stranger anxiety. Depends if your child's raised around people, and I use sheltered, and I don't mean that in any disrespect. It's just may be where you're located at. There may not be a whole lot of nothing besides family. But if they're not used to the strangers, they're gonna have that like, oh my God, who is this? Why are you in my home? They may be unhappy about being restrained or held for a procedure, because when you go to do these on a toddler, most likely if I start an IV, I'm gonna have to put their arm on a board and splint their arm to where they can't move. You're probably gonna restrain these depending on, and you can use a KED to restrain them very well. Previous medical experiences may lead to hesitation towards you, because at if any point they've been hurt due to going to see the doctor for a shot or anything like that, you're automatically the bad guy too. It don't matter how sweet you are, it don't matter how pretty you are, good looking. Now, cause you hurt me, and you're like, I don't know who you are. So be cautious of that. If a parent or caregiver is unavailable, reassure the child that using simple, calming words and just say, hey, buddy, my name's Chris. What's your name? And start from a distance, slowly get closer, and then talk about their shoes and work your way up. Maybe their shorts or their knees. Something to that effect on why that they may be, so you can be there and get a better assessment on them. Preschool age 3 to 6 have rich imagination. Yes, they do. That's about as best as I can tell you. Their imagination runs wild.
Ain't that the truth?
Mine at 9 still does. She talks and plays school, and she beats the heck out of her baby dolls. And I'm like, what they do? They talk to my class. I'm like, girl, you can't even shut your mouth. How you gonna beat somebody? They start believing that injury may be a result to a bad behavior, and that may be something that's instructed or told from a parent. So be cautious on that, and then reaffirm them that they haven't done anything wrong to cause this. This is something that happened due to results of an accident. They can't understand directions, so be very specific when you're talking about areas. Say, be like, where? Show me where it hurts. It hurts here. It hurts all over. Well, I got that. And that's why we went with the smile chart. If you notice, you got the frown face all the way up to the smile. I need you to tell me which one you are. Despite increased ability to communicate, much of the history must be obtained from caregivers. They're not going to know what they're allergic to. They're not going to know what medicine they take. I'm 41 years old and I don't know the name of one of my medicines. I'm like, I don't know, it's a shot. Well, how do you take it? Weekly? What's it for? I don't know. Doctor said take it. I have no idea. I'm 41 and I'm teaching y'all. I don't know. Don't lie to these patients, man. Oh, come on. Let's not. They need to be told, is that gonna hurt? It may hurt a little bit, but we're gonna do it as fast as we can and as great as we can because we don't want to do it again. So when I do this, I don't need you to pull, jerk, or fight me, okay? And here's why. Begin the assessment of the feet, move forward. We talked about that. Use adhesive bandages to cover the site of the injection or other small wounds. Modesty is developing at this age, so keep them covered as much as possible. School age, 6 to 12. My baby's in this group. First off, she don't like clothes. She don't want. I'm like, baby, you got two older brothers running around here. They don't need to look. So I'm not real sure modesty's in my house, but that's on her. I'm kind of still weirded about that as her daddy. At this stage, children begin to understand death is the final stage. They don't know why death takes place, but they understand that it takes good things away. A grandparent, maybe a parent, and they're afraid that no matter what has happened, that they're going to die too. So you need to possibly explain, be like, this is only a broken bone. You're not gonna die from this, but please make sure that it's not septic and you're lying to them because they may haunt you forever. Assessment begins more like an adult assessment. General impression, where you're at, what does it look like? Ask questions to the baby. I call them all babies, but ask questions to them. The child is probably familiar with the process of physical exams. Start with the head to work towards the feet as the adult assessment. If possible, give the child choices. Ask only the type of questions that let you control the answer. Don't, which one hurts worse, the toe or the foot? It's all the foot, but you control those answers. Don't ask open-ended questions. Allow children to listen to their own heartbeat and teach them, educate them on the equipment that you're using. Tell them what it's going to do. Say, hey, look, put this on. You listen to mine and then listen to yours. Ask the parent or caregiver's advice about which distraction will work the best. Give them sample examinations about what is causing their pain and what will be done about it. Remember that once we get to the facility that we don't know, and they may change it, but we didn't knowingly lie to them. So we talk about adolescents, 13 to 18. This is really when you want to start beating your kids and trying to get away with. No, I'm just kidding. My 17-year-old, he's very, very, very respectful. I think he's a great kid. We have some these days that are just like the worst. I actually have a 13 and a 17-year-old and a 9-year-old. So I have a variety of age. Please feel free if y'all want any of them. I'll ship them to you. You don't have to do a return label, so FedEx won't return them. So think about time. Let them know that, is this going to leave a scar? They're going to be more concerned about that versus the adults. You're like, no, I don't really care. I mean, I got scars all over me, arms, face. I'm just like, they tell a story and half the time I can't remember it. But at the adolescents and the children, they're more concerned about appearance. What's it going to look like? What's it going to happen? An EMT of the same gender should take care of them if possible. If not, allow mom, dad, somebody else to assist in that matter so they can be present and just say, hey, look, mom, is it all right if I, show you to do to you what I'm going to do to the child? Let them see that it doesn't hurt you, and I'm going to explain to them. I have the adolescents be able to give directions in their care. Because it's showing them that you care about their care, about their decisions, that no matter what happens is important to you, as well as them making their own decisions. Ask them to speak openly and ask questions. Risk-taking behaviors are common at this age. It just be explainful. I mean, we're not a parent, so it's okay if we're more truthful than the parents are. I'm a realist, and my kids will tell you in a heartbeat that I'm probably the meanest one that they have, because I tell them all the time, you ain't got no friends, nobody likes you, you mean. Like, they don't like you. This world's mean, man. This world is rough. I want to set my kids up for success. I love them more than anything in this world, but understandably know that they make mistakes and stupid things happen that we all have to answer for them. If you're jumping on a trampoline and you're trying to jump over the fence and you hit that fence, that's what you deserve, but we'll fix your broken leg. So tell these kids that it's okay to make mistakes, and that no matter what going forward, we're going to learn from this, and we're going to do everything we can to take care of you, and blah, 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 blah. But again, don't lie to them. Be forthcoming with information. I like to inform people that don't go to the ER much, that aren't frequent flyers. They don't know what's coming. They have no idea what takes place in the ER. So tell these patients, hey, when we get there, somebody's going to ask you a lot of the same questions, but now you can be prepared to answer for yourself if you're okay with that. So in this adolescent stage from 13 to 18, and then they become an adult, they potentially can be pregnant. Just keep that in the back of your mind. Again, don't always assume that they are, because that is very misleading if you assume that they're pregnant. Now, if they're of childbearing age, they're always pregnant until proven otherwise, with abdominal pains and things like that, and genital bleeding, stuff like that. And just because you don't know that, we can't give them field pregnancy test breathalyzers. You know what I'm thinking about. So understand that. They know that pregnancy is involved, and then they'll get scared, and they may tell you when you're one-on-one in the back of the ambulance. But again, tell them, say, hey, look, it's okay to be honest with me, because some things that we may do may alter the medications we give if you're potentially pregnant or you're on any sort of drug. I just want to make sure we give you the right medicine. So the body is growing and changing at all times through here. At the younger age, I think 8 to 9, little girls start to have the little buds, and they move forward. Daddies can't handle that. That's not what's supposed to happen. Young men start to have the dropping, their voice changes, the cracks. Young girls, I don't know, I'm just gonna say 10's a good age, start having their cycles. So all things take place in that age frame. So that's why we tell you, please give them the respect. Please give them the ability to tell what's going on from their side. Let them know that you care about what they say and how they say it. It's just that right this moment, I need to hear from your mama or your daddy. And it's not clicking. All right, so the respiratory system. So anatomy of pediatrics are different from adults, but they're just smaller. Pediatric airway is smaller in diameter and shorter in length. So the lungs are smaller. The heart is higher in the child's chest. So it's going to sit more around the clavicle area than it is down about mid-sternum. Yes, you're still going to do CPR the same exact way, but knowing the anatomy and how things move, because gravity does move things and allows it to set into the cavity of the body more. The glottic opening is higher and positions more anteriorly, so it's more towards the back, and the neck appears to be non-existent. I don't really know about that. I mean, I don't think that would be the case, but they get paid a lot more than I do. As children develop, the neck gets proportionally longer, and the vocal cords and epiglottis achieve anatomically correct adult positioning. The occiput is larger and rounder, which requires more careful positioning in the airway. The tongue is larger, relatively the size of the mouth, and is more anterior in location in the mouth. The child's tongue can easily block the airway. Long, floppy, U-shaped epiglottis in the infant and toddler is a lot larger than the adults. The rings of the cartilage in the trachea are less developed and may be easily collapsed if the neck is hyperextended or hyperflexed. So the upper airway is a narrow funnel shape compared to the cylinder shapes of the lower airway. So again, they're similar, but they're different from an adult because they haven't had time to build that rigidity, the stiffness of things. Sometimes when they fall like this, they do crush that. They don't crush their airway, but they collapse the trachea, and they're just not able to breathe. Click. The diameter of the trachea in infants is about the same as drinking through a straw. The respiratory rate starts to bellow off about 20 to 60 breaths a minute. Then that's normal for just newborns. The higher the number, the more for newborns. Their respiratory system requires a lot more. You're used to it, I'm sure by now. Children have oxygen demand twice as much as the adult because their body moves and burns so much faster. They need to breathe with it. Just because they're burning off all that energy, they gotta have oxygen too. So the muscles of the diaphragm dictate the amount of air in the child's inspiration. Anything that places pressure on the abdomen of a young child can block the movement of the diaphragm and cause respiratory compromise. Must use caution when applying the strap of the spinal mobilization device because it may hinder the tidal volume. So what they're trying to tell you is yes, you need to secure them to the backboard, but the strap that comes over the chest, the best thing to do is make sure these two fingers sit on the chest and go up and down just like this, and that you can slide the two fingers in and out of once you put the spider straps on. That's as tight as it needs to be. Gastric distension can interfere with the movement of the diaphragm. They get gas on their stomach. They have these crazy air bubbles as they're growing. Breath sounds are more easily heard because they're more inside the inner of the chest. So you're not having to try to differentiate between, is that gastric sounds or lung sounds? But when where they're located in the child, it's so much easier to find. You do have less air exchange with each breath, so the detection of poor air movement can complete absence or breath sounds may be more difficult. There's not moving as much air, so again, it is harder to determine your overall tidal volume. But knowing and hearing the breath sounds, it's right here in this chest that's already thin, so it is a little bit more helpful. Let's get to this one. So here's a chart again on your response for pulse rates. I would know these. I'm not gonna say you're gonna see a 205 heart rate. That is ungodly high. Maybe like the 160s. Maybe
Newborn,
in the upper.
Newborns are 167, 150s. Newborns.
Just say that's SVT for a child. That's supraventricular tachycardia in a newborn, because you're gonna be able to do a CPR a little bit, slow that thing down. So the greater in age they get, you notice this pulse rate right here starting to get to around Well, we normally have. We've discussed this before. I hope y'all have already made some note cards on your pulse rates. Definitely look over those. Make sure you know those. Not memorize, know them. So the nervous system it's an infant too. It is undeveloped. Head to body ratio, the infant is just proportionally larger, so they got big heads. So when they fall, they always, most of the time, fall head first. They sometimes have permanent knots on their noggins because of big old heads make them trip and they just fall over head first. I pick on my wife all the time because my wife set our baby on a table at a restaurant one night, and she got distracted and she took a tumble off and landed, and there's like a permanent knot on my daughter's right side over here. So I say it's my wife's fault. She put a speed knot on her head, but I always get told to shut up most of the time. The subarachnoid space is relatively smaller. It does have less cushioning for the brain, so that's the reason why you get more brain injuries. You can have swelling and there's nowhere for it to go. The brain tissue and cerebral vascular are fragile to prone to bleeding from shearing forces. So the shaken baby syndrome, the violent force of jerking up a child is the same way. That's the reason why you don't want to jerk and pick up a baby by their arm, because you can cause a green break and extend that arm and pull it out of socket. So much easier because that's their arms aren't fixed like ours. I mean, I'm gonna tell you, if you jerk me up like that, you better have some dang good reason or we finna fight. I'm just don't jerk me up like that. It's the same thing we shouldn't do to our babies. Even when you go to pick them up, don't pick them up by one arm and jerk them. I know that there's those one-time incidences, and we're not talking about like that. We're talking about every single day. That's not something you want to do. The pediatric brain does require a lot more blood flow and oxygen, because think about how much is burning. Their little bodies and their hearts. So they gotta have more. That ATP is got to be used when it's time for using of the energy and the building blocks of that glucose, because it needs it. It's got to go somewhere. They are more risk for brain damage and hypertension and hypoxia events because they need so much more. When you shut that hypoxia, that air drive off, they're gonna have more brain damage because they need that oxygen. I mean, I guess you can say we know what's so wrong with some people in our world. When you were like, man, what's wrong with them? They must not have had oxygen when they were babies. They cut that stuff off to them, and they just now just like, he ain't right. Maybe mentally, but if the cervical spine is injured, it is more likely to be an injury to the ligaments because of the fall. For suspected neck injury, perform a manual inline stabilization. So anytime that you suspect a pediatric that's going to have neck injuries, maybe slip, trip, and fall from a height, maybe did the scorpion where they landed when their feet came over, things like that, try your best to keep them in the inline position and stabilize it. And the reason why is you don't want them sitting here doing this, because since it is so small, there's no much air if they happen to cut that spinal cord, because it is, I mean, it's tiny. So, and you're not going to have a seat collar for every single size. Your agency may only have the adjustable kind. Sometimes those get a little aggravating. They don't ever really like fit right. But try to put that seat collar on and hold them inline stable. Let's see, the Gastro Distension, Gastrointestinal. Again, everything's smaller, so there's not much. They ain't got no muscles on their tummy. They don't have a six-pack ab or anything like myself. So, but their liver, spleen, and kidneys are larger, and they're more susceptible to damage when there's an issue. You got to think about if there's traumatic injury, that liver, kidney, and spleen is going to have more, because they're bigger and nothing's protecting them right now because it's all compressed too. They are more prone to bleeding. Obviously, the spleen is going to bleed a lot if it's ruptured. Children's bones are super soft. They are more like your geriatrics at this point. That is closer to age. You come in the world wearing a diaper. Sometimes you go out wearing a diaper. Think about their bones deteriorating through time. So it's about the same thing of the density for those bones. So be cautious in both of those on slip, trips, and falls for your pediatrics and your geriatrics. Growth plates, have to be very careful about if there's an injury in that growth plate. I know we talked about it the other night, but those open growth plates allow the bones to grow during their childhood. So if there's a fracture around a growth plate, be cautious of that because it's going to need to be splinted and taken well care of, and they're going to have to go to a facility anyway. Bone length discrepancies can occur if there's injury to the growth plate. It may be hereditary that they've had one limb longer than the other, or they may have had a birth defect, but let's not that be on us. If we didn't splint it correctly, we didn't provide them with the proper medical care, that can be our fault. None of us wants to live with that over life. If something happens and it's on us. We want to make sure that we provide them with the utmost care. So if it's, don't just sandbag that patient, if that's the best way I can put it. Bones in infants in the head, they are flexible because remember those growth plates, they'll move and all that until they get situated about the 13 and older range. They start to get a little bit harder. The fontanelles can be used for assessment. So if there's the fontanelle is sunken in, that shows signs of dehydration. You can also feel them in a little spot on the top of the head. If that is depressed, a lot of times that is a #1 sign of dehydration. And think about this: anytime you walk into a facility, or Rebecca, like with your kids, and the doctor comes in and checks them, the first thing that they do is they're like, "Oh, look how sweet," and they stop about here and they wiggle that index finger, trying to feel that soft spot to see, is it depressed or is it sticking out? If it's sticking out, then that potentially means dehydration, traumatic issues, and there's maybe some swelling in there. The thoracic cage in children is highly elastic. Same thing for their ribs. It's not so common to see children with broken ribs because of the elasticity in their ribs. It's not been solid and firmed up yet. The ribs and vital organs are less protected by muscle and fat. That's why I try to say I try to keep this this 6-pack ab because it try to protect my insides. That's just my story. I'm gonna tell it as long as it's mine. The integumentary system is the pediatric population. Differs in a few ways. The skin is thinner because remember they don't have much dead skin. They haven't been growing their skin for a lengthy period of time. The composition of the skin is thinner and tends to burn more deeply and easily with less exposure. Again, think about the density. Okay. Think about the density of the skin. It's very thin. So if you think about it, heat exposure or cold exposure, their body's going to react so much faster than ours because mine's got some layers of fat to go through. My little girl was learning about polar bears. She's like, "Daddy, you got blubber." No, baby, no. Daddy's got fat. There's a big difference. So think about that, and that's the reason why sometimes we're able to withstand cold longer than they are because we have those extra layers of skin. So our patient assessments, that's the same. We're gonna go over that. Note the position found. That's the same exact thing. All right. So here they talk about the PAT. It's the pediatric assessment triangle. This can be done in about 30 seconds or less. Our objective is to identify the primary threat for immediate or potential life threats. That needs to be done a lot faster than adults because remember, they're going to compensate and they're going to crash a lot farther than the adult. So PAT consists of 3 elements. You have your appearance, work of breathing, and circulation. What are those? What I need to know, how are those? So when we break it down, So the appearance is the level of consciousness or inactiveness of the muscle tone. This will provide you with information about the adequacy of the patient's cerebral perfusion and overall function of the CNS. The mnemonic TICLS can be used to determine the patient's sick or not. TICLS includes tone, inactiveness, consolability, look or gaze, and speech or cry. Never use that. I don't know that one. That's a new one. So their work or breathing. The same thing we're going to do with adults, but are they having to work harder to breathe than normal? Now, that's hard for us to say because we don't know these babies. I don't know if they're having trouble breathing. It looks it. And then you find out that they always been breathing like that. They from South Mississippi. They big. But again, look at their body. Is their body seesawing? Are they using accessory muscles? They're breathing with their stomach instead of their chest muscles. Look for rise and fall. Yes, you're going to have the speed and the elasticity of it, but is it more than what normal would be for somebody of this age group? Be cautious because, and ask, when I say this, ask, is that normal for them on their rate of breathing? Do they normally breathe like that? Well, yeah, that's the way they've always been breathing for the last 10 years.
I will add to that.
Come on.
Whenever my middle child had RSV when she was a baby, that was one of the first things that they asked me, does she normally breathe like that? And I'm like, no, absolutely not.
And you know your babies. We know them. We know how they act, what they cry. We know their different cries because a lot of us will sit there and hear them crying and be like, that ain't a hurt cry. We can hear them holler and scream. That's not a hurt scream. But when it is, you about break your neck trying to get to them. So listen to the parents during your assessment and ask these kids, hey, are you having any trouble breathing? Or you feel like you can't catch your breath? When we ask them, they don't know I don't know what I'm supposed to like. Am I not supposed to breathe like this? But they know that if they're out of breath, because they've all run at some point. So getting the best information we can from them is going to help us out during our assessment. So when we check the skin, it's really hard to check the color on the skin because it changes so much in the pediatrics because their skin is just, it's learning. You can get the blotchy skin on one and then the flaming red on the same one and you're like, I don't know. But cyanosis is always going to be there. The blueness of the skin, the nail beds are changed to colors because if you look at your nail bed now, as my nice well-kept fingers, and you squeeze it, it goes from white to pink relatively fast. Theirs won't because they don't have that oxygen level, the storming of oxygen cells and all that, and that's what you're doing. But you can say, well, their nail beds are pink, or purple, probably cold, or they're hypoxic. So, but the cyanosis, you'll see their lips, poor little baby's lips, and they're going to tell you that they need oxygen because looking at them, you're like, they look pooey. I need to, oh, no wonder everybody's looking at me because I got to do something. Now it's your job. From the PAT findings, you will decide if the pediatric patient is stable or requires emergency care. Duh. It ain't easy, but sometimes that's now our decision. If the patient is unstable, assess their XABCs, treat any life threats, and transport immediately. If the patient is stable and they do continue with the remainder of the patient assessment process, perform necessary interventions and discuss transportation options with the parent or caregiver. Anytime that it is a life-threatening injury, we are allowed to make decisions for the benefit of the patient. So if they're like, they're almost dying, and the family's like, he needs to go to, First Presbyterian Baptist of First Street. That's a stroke hospital. He's dying because he's missing a leg, bruh. We can make decisions for them at that time. We can tell family, hey, if that's where you want to go, that's fine, but I'm not going there. We're going to the trauma center. They almost killed mama in 1946. Well, today is 2020 and 2021. We going where I say things have changed. And you go, because we make the better decisions for that patient. But again, let me say this over and over. Follow what your local protocols say. Upon transportation of certain patients, make sure you just listen to what they tell you to do, and we're going to be okay. We're going to keep rocking along. What time is it? Yeah. Y'all want to take a quick break? Man, I know y'all ain't talking a whole bunch, but y'all want to take a break?
I don't care if we take a break or not. It's up to them.
Yes, I'm take a
Hey,
break.
what?
He's not
Yes.
talking to you.
That's right there. That baby wants to take a break. Good, because I'm going to take a break real quick. I'm going to go get another bottle of water. So give us, let's say 10 minutes. We'll be right back. 10-minute break. All right, y'all. We're back. We're about halfway done for the night anyway, so that'll be pretty good. Hang on, let me get this camera back on. All right, so all right. Oh, button. All right, so the airway. Oh, let's see. If the airway is open and remain open, assess respiratory adequacy. If the patient is unresponsive, have difficulty keeping the airway, ensure there's proper position. So head tilt, chin lift. If you don't suspect any trauma, use head tilt, chin lift. If you're unsure or unknown, make sure you use that jaw thrust. And we're just preserving that the spinal cord and us not knowing. And it's easier to assume for the worst and just use the jaw thrust before we know, unless we're 100% sure. Airway position in the airway is a neutral sniffing. We know this is when I talk about that, you want, like when you smell and smell up. So that's the sniffing position we want to try to put them in. And that's patting the back of the neck, not the head, because on most children, you'll notice you can feel, and then it's kind of got a little flat spot right up in here. You can put their heads in kind of the anatomical position, and sometimes they'll stay. And it may require you to use a little padding collar back behind the neck, between the gap of the neck and the shoulder blades. And that'll help that. Listen to feel technique. What do we see? What do we get? What are we being able to pick up from our hands, eyes, and ears? Let's place both hands on the chest. Look for chest rise, fall of the chest. We may not be able to see, and that's okay. Use your digits. That'll help you understand the patient better. Place your hands on there. Do you feel it moving up and down? Yes. Belly breathing in infants is considered inadequate of the soft palatal bones in the chest and the strong muscular diaphragm. So that's not. It is considered adequate. I misread that. So if you see those accessory muscles and they're for infants, it's more because they don't have those defined muscles in the chest wall that help with that. So you're gonna see those the stomach breathing, because that's helping move that diaphragm, and that's how they know to do it until they get those chest walls built a lot better. Circulation, if it's red and blood and it's coming out, red and wet and coming out, stop it. That's the best thing we want them to do. We don't want to, continue to watch that a life-threatening issue, and we can fix that and let it go. Address it, fix it, continue on with your assessment. Weak or absent peripheral pulses indicate decreased perfusion, so something's going on causing them not to be able to pump blood right. Tachycardia may be an early sign of hypoxia or shock. And the less serious conditions such as fever, anxiety, pain, or excitement. Interrupt the pulse with the context of the overall history, the PAT, and the primary assessment. A trend of increasing pulse rates may suggest a worsening hypoxia, because think about that. That's the reason why we get the baselines and continue with that, so we can look at that and be like, the vital signs just don't look right. On most kids, you can feel their skin, and they'll tell you. Some kids wear their temperature on their head, and as a parent, I know my oldest wears it on his head, and my daughter, she wears it on her chest. You have to feel her stomach. You can feel her head 24 hours, 7 days a week, and it's ice cold. But if you feel her chest, that's what tells you if you have a temperature. Estimate the capillary refill time, because they're not 100% accurate in children. If you'll notice, that's the reason why when you go to the hospital that they put the Band-Aid that sticks to their finger, because it holds pressure on there and it doesn't allow the probe to get a little loose. Granted, and yes, they can pull it off and you get tired of doing that. But that's another part of that. Some disabilities, check for the pupil response. What is their eyes telling me? Is it delayed? Are they non-reactive to light, or are they reactive to light? Look for symmetric movement of the extremities. Is it supposed to happen? Does it go up and down, or is there a scoop in the arm when you look at it and there's a big, and you're like, that don't look normal. Pain is persistent with most types of injuries. So if you suspect a decent MOI and you're like, what's wrong with this baby? He ain't crying. He's not acting right. That's where the ones that you want to draw that draws your attention, be like, what's going on? I don't know. When you assess them for pain, be careful. Their pain levels may go up. See what they can rate that pain level to. So you're like, hey, describe your pain to me. What's the worst pain you ever felt in your life? Okay, and then choose a number from there. Okay, having your tooth yanked out was the worst painful thing in the world, and that's the number 10. So getting a number 1 is when a leaf touches you. Things that they will know for their development. So make sure you relate some of those questions to their age development also. We know on exposure that children, infants, newborns, all that they don't mediate temperature well. They regulate it very weird, and it's like this is not working. What's going on here? So keep them warm, keep them covered at all times. The pediatric population is more prone to hypothermia events due to the immature thermoregulatory system and the thinner skin and the lack of subcutaneous fat. There's a benefit of being thick. The hands-on ABCs require the caregiver to move part of the pediatric patient's clothing to allow observation of the face, chest, wall, and skin. So when you do that, do it rapidly because you want to keep them warm as possible and keep them, if you know the patient is in shock and they're shivering, you need to turn the heat on even though it's 900 degrees during the summer because it's about your patient, not your caregiver. Yes, that's hard because you're like, I'm the one that's dripping sweat back here. Granted, but they're the ones dying. So if you can tell that your patient needs the heat, turn it on in the back of your unit. Keep them the best thermoregulated as possible. Let's see here. Transport decisions, depending upon your protocols for your agency, but most children are going to need to go to a pediatric hospital. It doesn't have to be a pediatric trauma center, but they need to have pediatric specialties. The specialties of those facilities is what is needed. And yours may be a pediatric trauma center. Reginald, do they have a pediatric unit up there, or is it just the med in general?
I know they used to, because that's where I was born.
So we have all divisions up. Like prime example, now that they have it separated for the pediatric. So if the babies come in, first of all, if they look like an adult, they stay in at regional 1. Even though these 16, 17-year-olds be coming in, they look grown as hell. I mean, they look grown or whatever, but they stay at regional 1. But the pediatric people, the baby, they don't come in, they direct them straight to Labana, which is connected to regional 1.
Right. That's what I thought. I thought so. If you guys ever get to the point where y'all have to transport into Jackson, maybe a ground transport or something like that, University of Mississippi Medical Centers in Jackson, Mississippi, there's one ER entrance, the adults on one side, pediatrics on the other. So we differentiate them, the same thing, by age, by looks. You're like, you sure that's a 10-year-old? Because he got body hair. He needs to go over there. So we do the same thing. When we give our report to MedCom, and I think y'all have the same thing, is at the med is they tell you which one to go to. And when you tell them a wait, they may say, oh, well, direct that patient over to the adult side. And they may call over to the ped side and ask one of the physicians to come over, and which is no big deal. They all work for the same facility. Let's see, rapid transports. It's going to be the same decision making that we do in adults. Do we stay and play? Do we load and go? Why are those decisions need to be made faster? Remember, no matter what, those children are going to compensate much faster than the adults, and they're going to go downhill a lot faster. So what we assume is a stay and play, once you get that second dose of vitals, you're going to be like, oh, we needs to go. That's not saying, remember in your transport decisions that you can upgrade that level of care. That's easy. Hey, bro, turn lights, sirens on, let's go to the hospital. Notify your dispatch center and tell them, Abnormal level of consciousness. If it's just not, if you don't feel warm and fuzzy about it, probably want that thing. Lights and sirens, go to the hospital. Because again, we are like a band-aid station for them. They need to get to the facility to where that is most beneficial for them. Not saying that we can't do anything for them, but remember where we're at, what we're doing. We just may not have everything in the truck, and they need a physician. That's why we would go faster. Let's see, potential serious and anatomic abnormality. If it's something that ain't supposed to be there, or that arm's in the wrong position, that's another reason to do a rapid transport. Let's see here. Also consider ALS, whatever your local protocols are, your comfort level. Nobody can ever tell you, like, I wouldn't have taken that license sirens to hospital. I'm glad you weren't, but you didn't make that call. I did. I made the decision. I don't like to hear people quarterback calls, so be cautious in that. And don't wear your feelings on your shoulders in EMS, because they will eat you alive. But if you don't feel comfortable in that situation, let's go. Things you can ask is, can I deliver the pediatric patient to the most appropriate facility without risking the delay of care to this pediatric patient? If you can't answer that, transport the pediatric patient to the closest facility. If you're already coming for some distance and that patient changes, you may have to stop at a local facility. Just because they don't specialize in pediatrics, as in the Med or Le Bonheur, doesn't mean that North Star Med Center, or for y'all may know like North Mississippi Shock Trauma Center, which they're not really. That still means that they can care for them. They're just not a specialty treatment center. So it's not saying that you can't stop there because something's wrong and you need a higher level of care. Patients with less than 40 pounds who do not require spinal mobilization, patients should be transported in a car seat. If they're supposed to be in a child safety seat by the state law, always transport them in a child safety seat. Now remember, if they're involved in a car wreck or a situation like that, that car seat may be jeopardized in its integrity. Be very careful on that. You want to mount that car seat to the stretcher. If you've never done that, it's just like putting it in the back of your vehicle. It's just strapped in different because it's got a lap belt. Patients younger than 2 years must be transported in a rear-facing position because of the lack of the mature neck muscle. Patients who require spinal mobilization, the patient should be immobilized on a long backboard or other suitable spinal mobilizing devices. That's why I say the KED is the best at putting these patients in spinal mobilization. And you can lock their arms down, they can't go nowhere. Now they're gonna scream like crazy, but you can also secure that to the stretcher and it provides them another bit of safety. The pediatric patients and cardiac arrest should be on a device that can be secured to the stretcher. Pediatric boards, some are so small that you can use CPR boards in certain places. You should not use a pediatric patient's own car seat if they're in cardiac arrest. The goal is to secure and protect the patient for transport in the ambulance because, again, we don't want to cause no harm to anybody. History taken, the biggest thing here is the same questions that we want to ask family or ask an adult patient we need to ask of this child. Now, if they're of age, of childbearing age, when you go to ask the question on their sexual activity, be cautious where and how you ask that question because you got the possibility of pregnancy, maybe have drugs and alcohol, and mom and dad may just not know. Questions of the patient and the child should be immediate illness, and it should be related to the child's chief complaint. if their ingrown toenail has nothing to do with your patient care, don't act. It doesn't matter. Let it go. That can be found on the secondary assessment, and you can mark it later. We know that the younger they are, the more questions we're going to have of parents, but that's the younger down the road. We'll just have to ask on age dependency. If these kids knows what they're doing and they're on their game, ask them the questions. They may not know when the last tetanus shot they had, but if they're a juvenile diabetic patient, I bet money they're gonna know more than you about it. So ask them. We're interviewing a child care provider or a parent. Make sure you know what's written right there. I want to know what is normal for the child. Okay, then what made you call me here this evening with this type of complaint? Are they not eating and drinking correctly? Do they not have the same activity level? Or do they have a small fever? Is it slip, trip, cough, coughing up mucus? Tell me, I don't know. Okay, is that not normal for them? And what you're telling me what is normally present for this child? Sometimes that may be your introduction into an abuse case. So ask these questions up front, get the best answers that you can, and rock on with it. You may have chances in bowel or bladder habits. Ask questions, maybe they're impacted. Presence of rashes, obtain name and phone number of caregivers. They're not able to come with you to the hospital. Even child care facilities, if a child has to be transported from there to a facility, take a caregiver with you. Depending upon the status of that patient, you may not allow them to ride with you, but tell them, hey, if you leave now, you can meet us there because you're going to be the primary point of contact until a parent shows up. Sample questions you're going to have to ask an adult OPQ-RST is the same thing. Secondary physical exams, this is the same thing. We're going to go head to toe, and we're going to use our hands and look for decap BTLS. That's about as best we can do. Depending upon the MOI, you may have to stay into an area. If it's lower body or upper body, you may have to focus on that more, but understand that you got to get this information in a short period of time because you're going to drop them off at a facility, and they're going to be like, did the EMS do anything, or they just throw them on a stretcher and bring them here? So the better, more of information that we can gather to pass off, the better off we are. We talked about that, assessing at the feet. School-age children, you want to start from the top to the bottom, just in reverse. Physical exam, again, this is going over your secondary assessments. Here, when I talked about ears, look for bruises, weird shaped bruises, bruises that should not be there. Cigarette burns, lighter burns, things like that. Obviously, right there on yours, it shows a presence of pus may be indicated of infection. So let's take caution to that. The neck and chest, same thing. Decap BTLS, all of that as you're assessing it. Look for crepitus, abnormalities into the chest. If they're not able to expand fully, or they're ask them, how long have you been breathing like that, baby? I've been breathing like that for all my life. Okay, there may be something that's permanently there, not just that's an acute issue. On the abdomen, look for tenderness or masses. This is the time that you have to tell them, hey, I'm fixing to check your stomach. I'm gonna put my hand on there, my gloved hand, and check your stomach out. Look at the same time as you may see some bruising. Some of these children, depending upon the age, could be self-mutilators. I actually was reading an article the other day on that, and this one girl hid it for so long because she did hers on her waistband, and nobody could see it because you can't see the arms or anywhere other place that's normal. And I had never thought about that. Make sure the abdomen is good for distension. Rebound, if you tap it and you're checking the hollow or solid organs and you're doing your assessment right, does it have good rebound to it? Does it have, is it distended? Or, those are the questions that we need to check all the time. When you check their back, it's the same thing as you're doing a rapid assessment, but remember, we only get to check it once. So run your hand down it, make sure there's no blood, make sure you don't feel any penetrations, stab wounds. If you rub your hand down, well, I like to use my fingers. I'll put a little bit of pressure as I come down. And if there's a hole or anything, your finger will dab into it. And then check your hand periodically, make sure you don't have any blood. Extremities, DCAP, PTLS, make sure they have a good PMS. And you can note on your reports PMS times 4, or if you do PMS times 3, you can say right leg past deformity, or the leg, there's no pulse due to leg has been amputated in past history. I've had that happen before, and I had it sent back to me because I didn't list. I did PMS times 3 with no noted issues, and I didn't document that the kid had an amputation due to a childbirth defect, and that got sent back to me in QR on that. When we talk about checking the joints, what I want you to do is be like, hey, need you to do me a favor, push against me, now pull. Can you raise your feet up? That's checking your joints in normal matter. I'm not asking you to do a full head to toe physical on them, but check for joints, because if you have swelling of joints and joint pain, that could be meningitis too. Vital signs, right there is a big one. The last bullet on yours, that's probably a registry question. You don't take vitals on any patient younger than the age of 3. So heart rates normally, that those from your charts and all that y'all have studied and written down, that you should have those and memorized pretty well on their vital signs. So knowing a good pulse, respiratory rate of somebody younger than 3 can give you a lot of vital information. Assessment of the skin. Once they're older than the age of 3, make sure you have pediatric cuffs, even if it is a manual one, because an adult cuff's going to look like you're trying to wrap it around their thigh or something like that. I recently had to order one out here that was a big boy cuff, because we got some grown men. We ain't got no little ones like they sent me out here. So you're using the right size of the equipment that you can. Assess skin is better indication of pediatric patient circulatory status, because their skin is the largest organ, remember, and you're going to start to have deficits on that before your body starts shutting down, because at some point it's got to shunt the blood, and the skin's going to take an issue from it first. So here's a way to get your vital signs. Here's a formula. The formula is, I'm not even going to talk that out, but y'all can see that on your screen. And that what gives you your systolic blood pressure. You can figure that up in children's age of 1 to 10. Respiratory rate, there's multiple ways to do it. Count your respirations rate for 30 seconds times 2. You can do for 15 seconds and times 4. You can do it for 1 whole minute, but that's completely up to you. I'm a 30-second kind of guy, and I multiply it times 2, and that's all I need. And I do it for any age. It's a habit. I'm a habit of creature. I decided to do the same thing. Normal pediatric vital signs vary with the age.
Just tap it.
I don't know. What y'all see?
Just your desktop screen of the
That right here?
little island.
Hang on a second. I don't know what's going on. It's back now on my screen. All right. That was. Now I just got to find the slide where we were at. That was odd. It's really odd.
How's your internet connection?
As long, I have learned, if y'all start having issues with hearing me, that's when we have bad
I
issues.
Infinity, you might need to invest in a new internet.
How am I going to invest in the internet? I don't even own this one. I don't even pay for this one. I got better internet out here than I do at my house. I don't know. I don't know what side we were on. I was just talking. All right, we'll start here. Sorry, y'all. I don't know what happened. So some questions need to be asked is how long has this baby been sick? What's going on? What was some of the things that led up to being sick? Again, a big question is why did you call me here tonight? What is different from 2 hours ago versus tonight? Well, I've had all I can do. I can't do no more. Well, that's a personal issue. I can't fix personal problems. But presence of fever, they can tell you if that, a lot of times fever tells you that there is an infection, something's wrong. Pediatric patients, their activity level, it's because most time they bouncing off the wall and they don't need that energy. But now that they're just like a sloth and they're just not doing nothing. What's their intake? What's their output? And what color urine it is. Now it's hard when you have that infant because they pee into a diaper and you don't really know it. But at ages, you can say, hey, when you go to the bathroom, don't flush. I need to come see that. I don't want you to send me with the bottle of urine to the hospital because that's not what I want. I don't like testing it out here, so we ain't doing that. Changing bowel or bladder habits. Have they gone to the baby? Have you gone poo-poo in a long time? When's the last time you TT? Have you had any loose stool, like where it just looked like water was pouring out your bottom? Does your tummy hurt? Some of those things can give you answers of what's going on. What am I looking for? Sample history, we talked about that. We know how to get our OPQ-RST. Physical exams, this is where you're physically putting your hand on there and doing DCAP BTLS. Did I cover all this already? Yes, I remember that one.
Yeah, you covered all that already. If you find the slide that shows that formula.
That it right there? Yeah. I was a couple
Yeah,
past
it was
that.
shortly. Yeah. Yeah.
Okay, so here, the same thing when we do vital signs. It's 5 to 15 minutes. That's not changing. Again, these are babies, small humans. They're not small adults. Small adult is maybe like a dwarf, or they're still in. But these are babies. Their organs are like that's their heart. I mean, that's little. Patients and caregivers may be able to assist you with information. Should, depending upon their, when I say their mental status, I mean is their ability to handle what's going on. Communicate and document all relevant information to the ED, because I'm not going to keep the information for myself. Let's let them know. Respiratory emergencies are going to be a very big issue because remember, they're like breathing into this versus us breathing into this. So theirs is going to take place early. Early stages, you may notice change in behavior such as combativeness, restlessness, and anxiety. That's telling you that the respiratory problems are beginning. Respiratory distress in the pediatric patient is working harder to breathe and will eventually go into respiratory failure if you don't do nothing. You got to make sure that you aggressively treat these patients and understand that, I just need to, let's put them on high flow O2. Let's get ALS here. I think that this baby would really benefit from breathing treatment because they sound like they breathing through a water hose. Nasal flaring, I sure can't make mine flare, but some people can. That seal in their chest, obviously we know seal bark coughing is a sign of a respiratory issue. What accessory muscles using in the tripod? A tripod is very, very key to a respiratory distress, and it's probably on the latter side of your respiratory failure part. Their efforts to breathe have gotten shit. They just got bad. Like, I have to do something. You'll notice the elasticity in the chest from going here to here. They're starting to they're labored breathing. They have less ability to breathe. The body has got all of its stored up energy and it's done. It can't support the work of breathing. They're literally wore out. You have to breathe for them. These babies need you at this point, and that's why I tell you to jump early. Don't be like, oh, it's gonna be all right. We're 15 minutes from the hospital, because in 3 minutes that baby's gonna crash on you, and then you're gonna be like, I don't even have a bag valve mask out. Whoops, you're gonna look like poo. I talked about the change of behavior. Patients may experience periods of apnea. Patients become hypoxic and have low heart rates. Things are slowing, like we said. They run, and that storage of ATP and all that energy is it's completed, and they have fought as long as they can, because now it's your job to have jumped on that and keep them going. Respiratory failure does not always indicate airway obstruction, but that is something that is indicated in trauma patients, nervous system problems, dehydration, metabolic disturbances. And we're not going to know the metabolic side because that's a lot. We got to pull labs. We need to check their CBGs, and CBG's not really going to tell you anything besides if their blood sugar's low or not. But I want to know metabolics later. Pediatric patients' condition can progress from respiratory distress to respiratory failure like that. A child or infant in respiratory distress needs supplemental oxygen. You may have to use the blow-by method, or you can use a smaller pediatric mask. Remember, on these, some of them may just not tolerate that. Keep them as comfortable as possible. Don't stress them out any more than you can, because you see that these babies have, I don't want to say they gave up, but they ain't got no more give, because they're tired. Here's obviously some small pictures of some things that can cause respiratory destruction. But if you fit that green thing in that puppy in your mouth, or that duck, you doing something. You doing something. You hungry. Anything can cause an airway obstruction. Any single thing. So look at the fourth bullet, where croup is an infection of the airway before the level of the vocal cords. Do y'all remember the little telltale sign I told you to keep? What is virus and what is bacteria? Do y'all remember that? Do y'all remember how I broke that down?
Virus is going to be short, so it's croup. And then bacterial is going to be
Epileptitis. Yes. So we can't determine that out there, because I can't pull your WBCs. I don't have a lab machine to spin and see what your levels are. But knowing when they come and tell you, be like, oh, they just had the croup. Well, that's a virus. They're good. So potentially that baby can get better. Or when they start getting that bacteria involved and their WBC's up, that baby's sick. And you find out later on, and you go back and check on them, and they just be like, thank you so much. And you're like, oh, I did it all. I do it for every patient. You're like, what I do besides drive here? So just knowing the difference can help you out a lot personally, and help you understand the progression of sickness for these children. So here's a airway obstruction picture. As you can see, this young lady has a very swollen epiglottitis. So what it's doing is it's constricting the airway, and it's making it very narrow through here. Yes, this is the little flappy valve right here for the food versus air. But you notice how thickened the epiglottitis is, and you can't get much down to the airway or into the stomach, and it's very thin. It's very red. It hurts. They go like this. I was like that last week. That you just feel like crap. It's a viral infection. Airway obstructions may be foreign. We don't know if they put something in their mouth. It could be partial or complete. We know that it's either half or full. Signs and symptoms frequently associated with the partial airway obstruction include decreased or absent breath sounds and stridor. Listen, I don't say rush out and buy you a $200-$300 set of ears, but I like my ears. I have a very nice Littman. I've had it for probably 20 years. No, probably 15 years. And it was $250, $300 back then. My physician, actually, and I talked with her a lot about it, she has the one that has basically like a little speaker in her mic, and it amplifies it, so when she listens to it, she can hear better. When you go to paramedic school, I tell you, you need a very good set of ears, because you will not wear them out. It is a very good investment. But if you're first starting out, you could do with a lot less cheaper one. I wouldn't buy the little flimsy ones that you sell from Galls, but get you a decent set of ears. Anytime you happen to hear wheezing or crackles, know that's a lower airway obstruction. You hear obstructions from decreased breath sound, stridor, or that is a upper airway. So that's how you can differentiate. And don't forget to you can YouTube your breath sounds and hear the difference in the wheezing, the crackles, the stridor. Is just the best way to train you when I don't have it right here in your face, and I can't just be like, this is, like a generator or a rhythm generator or breath sounds, and you can't listen to a mannequin and do it that way. The very best way to listen to it on both sides and at the level of the armpit. If you notice, most time when you go to your physician, they listen to you multiple places, and when they listen around front, they're listening to your upper lobes of your lungs, and they are listening to heart tones, and make sure they hear dum 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 dum. If they hear that blub 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 blub, that gives you difference that there's potentially a heart rhythm change or something, a PVC, PJC, one of those funky little beats they add in there. So they do listen to your upper lobes here, and then the back lobes, you can hear the top and bottom lobes, depending sometimes. Not, I'm gonna say every time. If the patient is conscious and coughing forcefully and someone saw him or her ingest a foreign object, encourage that baby to cough as much as they can to clear that airway. If they can get it up, the better off we are. If you see signs of airway obstruction, attempt to clear the airway immediately. Be careful using the finger swoop unless they're like an infant or something like that, because they can chop your finger off, and I like mine. I'm pretty attached to mine, if you get that pun. If an infant is conscious or complete airway obstruction, perform 5 back blows, forcefully followed by chest thrust. If the child is conscious and complete airway obstruction, perform abdominal thrust. It's also known as the Heimlich maneuver. Use the head tilt chin lift, finger sweep if the foreign body is visible. Remember, these are all just refreshed from your CPR class. Chest compressions are recommended to relieve severe airway obstruction in an unconscious patient. Excuse me one second, let me look at something.
While you're paused, there is this guy, Leah, do you remember what his name is? He's on TikTok. I don't even do TikTok. I didn't until my sister.
Ginger, I don't know. Was it that one?
I'll have to look and find his name, but he gives a lot of like scenarios and stuff, and he'll throw out like some questions that you might see on National Registry and stuff like that, and like little helpful hints to like memorize stuff.
Was it the Rescue Academy?
Yes.
I'll have to look that up. I TikTok because I got a little bit of time on my hand out here.
So so this guy, where he just help you out on different guidelines about the registry?
Yeah, like he'll take like some, I guess, old National Registry questions and read off the multiple choice answers, and then he'll be like, okay, now which one are you going to pick? And then he'll go through the explanation as to why you choose this one versus all the others. And then just like different ways to memorize. Like, of course, with Chris was talking about the croup versus the epiglottitis. Just different stuff like that to kind of help you memorize.
I just looked him up. He had a pretty cool little. Here's one right here. Look, here's another thing about croup. An infection of the airway at the lower, typically seen in children 6 months to 3 years. Starts with a cold, cough, low-grade fever. Develops over 2 days. Hallmark signs are stridor and that steel bark, and it's very common because you go, it's very, you're like, smoker? I mean, what's up? How long you been smoking? Your age is a big thing there. Look right here. Bronchiodilators are not indicated for this because it's a viral. And because see here you talk about epiglottitis. They have the sore throat, the high fever. You're gonna see these in tripod position because they need that space to develop. The epiglottitis can swell 2 to 3 times the normal size. That's where it gets real hard to talk and swallow. Those are going to be a bacterial infection there. Some of this can lead to or caused by RSV. RSV is very highly contagious. It's through droplets, the same thing as everything is right now. Everything's droplets. The bad thing about RSV is it can stay on a surface a lot longer than any other viral infection. So that's the reason why we say gloves, eyes, and face protection. The virus tends to spread rapidly through schools, and that's the reason why they don't. If you start to have issues like that, they don't want you there. They want you to go home and stay away from the facility because it'll run rapid through there. I was watching another thing on Facebook the other day about how fast hand, foot, and mouth is spread, and how it spreads to the adults too. So it is common out there. You see these things, and to the management of taking care of them. And these are some things that you're going to run into is these viruses, these infections that you're susceptible to. So that being the case is be cautious. Make sure you always wash your hands. Be very understandable about that. Bronchiolitis, bronchioles come in flames, swelling with mucus. Airway can be easily become blocked. Look for signs of dehydration, shortness of breath, and fever. This occurs in the first 2 years of life, more commonly in males. Yes, I'm glad we're separated from the rest of it now. High flow O2 is the best thing we can do there. Treatment. The more that they get worked up, the more of the effort to breathe, the struggle to breathe, all of that is what's going to take place there. So the calmer that you can keep them, the better off you are. The better that they have tendencies to not be stressed, not stress the respiratory rate. Humidified oxygen helps. Not all services carry that. That's more of an ALS skill, unless your service allows that. I don't know any services right around my area that will let you humidify some oxygen. But you see right there, that's the reason why they're calling for ALS backup, because they're gonna need that pretty quick. It is caused by bacteria spread via respiratory droplets, like we just talked. Bursitis is not as common in the U.S. We obviously, right now, we're hearing a lot about COVID. Like everybody's tired of COVID. You know, mask this, mask that, vaccines for children, whatever you believe. I want you to just be the most educated person in that and make an educated decision. I don't like talking about helping people make decisions when it comes to COVID. Typical signs and symptoms are similar. They do have common cold. sneezing and a runny nose that possibly is the flu. You know, that still does exist. As disease progresses, the cough becomes more severe and is characterized by the stinking whoop sound. You may think that as the whooping cough. Infants infected with bursitis may develop pneumonia or respiratory failure if untreated in a long period of time. To treat a pediatric patient, keep the airway and the patient open. Try to agitate them, keep their eyes open, focus on you, let them listen to you. If they rest comfortably, if they try to close their eyes and just relax, you want to try to put that oxygen close into their face. You see right there, bursitis is contagious, so follow standard precautions. So you want to follow your infectious protocols. If you know, that may require you to put a gown on, or certain type of N95 versus a cloth mask or surgical mask. Those are the things that your agency may require. And you're starting to get into the weather changes. Now we're getting into the winter months. Temperatures are changing. You're going to see these more persistent, because that is some of the stuff that happens when weather changes. We'll go through that through a couple months, and then we'll change again if people get real sick, and then we'll have 9,000 degree weather days. So that's bursitis is most of that. That's just in the first night. We didn't do too bad. About an hour, almost 2 hours right there. So we'll pick up, because I'm gonna tell you, it was another 114 slides, and I don't think we wanted to go another 2 hours. Again, I'll let y'all know what I decide. I really think we should probably just push this till Tuesday. Your final, you don't have a mod 4, mod 5 final. So these 3 chapters that we're going over will just be included into your overall exam. For your final, though, you do have to do this in person for your final boot camp that you will take. So make sure you take a computer with you. This is more of the registry type setting for this final. You will be allotted enough time to take the final. And remember, this is the final, so your final grade will be accumulated from all of it. I will, after we go into geriatrics, I will give you a couple of days to look at everything. I will hide your grades from you, and then at the end of it, I'll give you your final grade. It's obviously already calculated, but I will, because I don't want y'all to focus on that. We need to, we'll probably have a couple of reviews. I'm gonna try to get Rob. Rob's very, very, very good at this. To come in here and do a review one night with everybody, go over a few things, and then prep y'all for the final. All right, folks. Thank y'all. Leah, do you have anything to say? I saw your mic unmuted real quick. Rebecca?
Yeah. So I got a 68 on my test, but I didn't do a retake yet. But if I get probably the same score, like below a 75, like what happens? Because that's not passing.
You'll have to meet with the EMS. You have to meet with the EMS coordinator. I hear he's a pretty cool dude. So just shoot me a message on Discord. We'll talk about it.
Okay. Thank you.
So what you're saying about our final exam, we're taking that at our 4th boot camp? Okay. Just making sure I heard.
Take a deep breath.
I just making sure I heard it right.
It's gonna be okay. Okay, it's okay. The reason why I do that, the final is very nerve-wracking to everybody, and in some previous classes, I've had some attempts of cheating on the final, and it was proven through the website, but I couldn't. It was very hard, so now I made the decision that we do that at the boot camp, and your I don't know how they want it to do it. They'll do it at the beginning of the day, end of the day. I've always said you need to do it at the end of the boot camp. That way that you're very receptive to everything that you're taught. You understand your skills, and then you take your final, and you can be mad and pissed off at your own time. But that's why I made that decision. I thought that was the best thing to do. JB Learning does an excellent job on, I can tell if you taken too long to answer your question, you answered it pretty fast, or you've done some things, it flags it. I get emails, I have to go in and look at it, and I look at all your questions or your tests. So I get to see those. And I know how long it took you to do everything. From the time you open it to the time you click the first answer and hit submit. So if it's one of those, it's out of the way. Rob and I speak about it and we go forth from there. And we've had some blatantly do it and they failed out of the final test on the program. On them. All right, y'all, enjoy your night. You don't have a test tonight, that's on me. We will kick this off again. I will let y'all know what I decide on going forward. And if not, I'll see y'all Tuesday. Hope y'all have a fantastic weekend and enjoy yourselves. Good night, y'all.
Good night.